Everyone, today I'm going to be talking to you about my paper, which is entitled Ripping Off the Band-Aid, Ethical Considerations for the Use of Psychotropic Drugs in Children and Adolescents. So, there has been an increase in number of children and adolescents diagnosed with a psychiatric disorder, and it comes to no surprise that there is also an increase in number of children and adolescents being prescribed psychotropic medications. I believe these drugs to oftentimes be ineffective and in some cases even harmful to the well-being of the children or the persons that are taking them. Thus, I believe it is unethical for psychotropic drugs to be the first line of defense when dealing with childhood depression. Although we as behavior analysts are not the ones prescribing the medications, we oftentimes are dealing with clients who have a comorbid psychiatric disability or are on some kind of psychotropic medication. These types of medications obviously have effects on the client's behavior, and they can be as severe as aggression or suicidal behaviors and catatonic, or they could be as mild as a headache. The field of behavior analysts, like many other human service fields, abides by the overarching code of do no harm, and thus I believe it is the job of the behavior analyst to be an active member in dealing with issues involving psychotropic drugs with their clients. So as I was writing my paper, there were a couple hypothetical questions that came to mind. And considering that doctors have to take the Hippocratic Oath, they are required to take the oath that says do no harm. So by prescribing these medications, are the doctors doing harm to their clients, especially considering that there is no research to support a specific drug or that the research shows that there are adverse effects to this drug? So, is it the job of the behavior analyst to advocate against the use of psychotropic drugs? And if so, to what extent? When does it become that the behavior analyst is stepping over his or her boundaries? Also, it's important to consider that a lot of our clients will be on these drugs, like I mentioned. So is it ethical for the behavior analyst to take on such heavily medicated clients or to reject them? Either way, it's not the most ethical thing to do, and it is a dilemma. So behavior analysts must practice, teach, and conduct research within their domain of competence. So we don't want to be stepping on anyone else's feet. If you don't have a degree in medicine or pharmacology, then you're practicing outside your domain of expertise. And advising a client on how to navigate their medications or give them advice on what to do with regards to their medication is unethical and in direct violation of the BCBA Code of Conduct. So what about all the harm? So we're hearing about all the harm. What can we do about it? So as behavior analysts, the number one thing is do no harm. So I believe that it is our job as behavior analysts and as clinicians that are serving our client is to be there for our clients and to make sure that these drugs are not harming them in such a way that they can't function. And we'll go over ways how to do that towards the end of my presentation. So here are some history with regards to the use of SSRIs or antidepressants and how they are linked to suicidal or homicidal ideations. So instances like that have resulted in thousands upon thousands of lawsuits against pharmaceutical companies. And the number one pharmaceutical company that kept popping out was Eli Lilly and Company. So most of the cases that come against Eli Lilly and Company are settled out of court. So they'll just give the families of the victims lots of money and they won't end up in court. But there are a few that make it in front of a jury. And unfortunately, those who do make it in front of the jury don't have the best outcomes, as we will see. So the first one I'd like to talk to you about today is the case of Foyserth. versus L. Lilly Company. And this is a story of a man who, after taking Prozac for 11 days, became homicidal and suicidal. And he ended up not only stabbing his wife 15 times and killing her, but he also ended up killing himself. Another one is Potter versus L. Lilly, and this is concerning the case of Joseph Westbecker. And he went into his place of work. He worked in a post office or a printer's office, and he was armed with an AK-47, and he turned the gun on 8 of his co-workers, killing them and injuring 16 others before committing suicide. And this actually went to the courts and in front of the jury, and the jury sided with the pharmaceutical company. But throughout the process, it was later determined that the company actually had greased some palms and paid off some of the prosecution so that the case would not go to in front of a jury. So there are several other cases that are identical or very similar to those, and all of them involved either homicides or suicides. And most of them were either settled or they did not come out with a positive effect for the families involved. As a result of all of these lawsuits, the FDA requires that all SSRIs and antidepressants have a black box warning on them. And what this means is that there's a sticker on the medication that says that taking this medication will put you in increased risk of suicide or homicidal thoughts and behaviors. In addition, pharmaceutical companies are required to submit to the FDA for approval documentations regarding the drug's safety and efficacy, as well as text inserts. So here's some research on psychotropic medications. So the prevalence of use of psychotropic medication amongst adolescents and children is that 38% of children and teens in the system, like the Medicaid system, have a diagnosis of depression. 56 were prescribed antidepressants, and 66 of the antidepressants were SSRIs. And it's important to keep in mind that the SSRIs are the ones that are linked to suicidal and homicidal thoughts and behaviors. And what's even more astonishing is that 26% of the kids on SSRIs did not even have a diagnosis of depression. So here's some more research. Do they even work? What is the efficacy of SSRIs in treating the symptoms of depression in children and adolescents? So pharmaceutical companies, it was shown by Giordani et al. 2014 that pharmaceutical companies had over-exaggerated the benefits of their medication. It was actually shown that they were as effective or slightly more effective than placebos. And there are several other studies that showed the same effect. But for time's purposes, we'll keep it going. So side effects of the SSRIs or psychotropic meds in children is a bundle of behavioral side effects, and this includes motor restlessness, sleep disturbances, social disinhibition, and sensations of excitation. Another one found that SSRIs cause activation syndrome, and this is just a overall umbrella term for irritability, mania, SIB, and other symptoms. They also showed that SSRIs cause sexual dysfunction in teenage boys. And of course, the suicidal thoughts and behaviors. So what is the role of the behavior analyst? After going all of these ethical dilemmas and considering all of the research, what can we do? The behavior analyst should get involved. Just because it is outside of our domain of expertise doesn't mean that we should just not get involved and not advocate for our clients. I'm not saying that we should tell them to get off their medication or decrease it, but we should be there to take data along the way. We should collaborate with professionals like doctors, nurses, practitioners. Also, take into consideration the client's wants and needs. If the client is perfectly happy on medications, that's their prerogative. But if they're telling you, I don't like being on medication and I'd like to do something about that, then you have to take that into consideration and maybe incorporate it into the behavioral plan. And I also think it's really important to take data on the drugs. So always put in a phase change line or a dotted line to when they took their medication that day, or they forgot to take the medication, or it increased or decreased. Those are very important things to show that the medication does have effects on the client's behaviors, whether it be good or bad effects. And if the client is up for it, if you've talked to all of the professionals and it seems like a good idea to everyone involved, it could always be part of their behavioral plan to incorporate gradual drug reduction strategies. And lastly, it's always important to consider that although these drugs are widespread, we are in the field of human services. Our number one goal is for our clients to be autonomous and to lead the best life that they can lead without an extreme amount of harm. So we should always consider, are these drugs just making my life easier as a clinician, or are they making the client's life better as a person? All right, that's all I got. Thanks for listening, everyone.